Thank you very much, and thank you to the organisers for asking me to speak. I'd like to briefly refer to Boris's talk, actually. I'm glad that he has this rather naive idea that paediatricians know what they're talking about and thinking about with inborn errors of immunity. I remember a few years ago I was on call for our transplant unit, took a call from a paediatrician who was working at a hospital outside our unit. I have to say, in the UK, I work in Newcastle upon Tyne, which is one of two centres that look after patients and transplant patients with immunodeficiency. And you could say we're a centre of excellence. This paediatrician rang me about a preterm baby that had just come from our neonatal unit, and he was worried about a low platelet count and a low white cell count. And I said, well, I'm not on call for general paediatrics or infectious diseases, but only for bone marrow transplant. And he said, oh, you might be interested. This mother's had a bone marrow transplant. And I said, well, maybe. Anyway, it turns out that this mother had had a bone marrow transplant for SCID in our unit, and this baby had a documented history of lymphopenia, documented very well by our neonatal unit, who'd also noted the maternal history of transplant for SCID, failed to let us know about it, and indeed the child also had SCID. So not all paediatricians know, even in centres of excellence. Anyway, I've been asked to talk about immune dysregulation in the context of inborn errors of immunity. This is my disclosure. And I think it's worth just thinking that, most of the time the immune system works. I love this quote from over 20 years ago now. Remarkable capacity to maintain a state of dynamic equilibrium despite recurrent exposure to a diverse array of organisms and constant exposure to self-antigens. Of course, we're thinking about when it goes wrong. And this is one definition of inborn errors of immunity, which I think succinctly sums up what we've been talking about over the last hour or so: a failure to achieve immune function to provide efficient, self-limited host defense against the biotic and abiotic environment, whilst preserving tolerance to self. And that's really what we're going to be thinking about in this talk. And you can think, when we're talking about inborn errors of immunity, of a number of different manifestations, including recurrent multiple opportunistic infections, allergy sometimes, increased sensitivity to specific pathogens. Really, for this, we're thinking specifically of autoimmunity, failure of apoptosis, and malignancy with or without lymphoproliferation. And so we've heard that not having enough immunity can be a bad thing, but actually having more immunity than normal may also not be a good thing. This is a review, a cartoon from an article from Eli Haddad 4 or 5 years ago now, thinking specifically about STAT3, and we know about loss of function disease causing classical hyper IgE or Job syndrome. But actually gain of function, where we've got too much signaling, can also lead to significant disease. And you can see in that bottom on your right-hand corner at the clinical manifestations of gain of function disease are quite significant. I have to say this is not a new concept. My mentors, Andrew Kant and Mario Abanon, along with a trainee who was training with me at the time in Newcastle, actually thought about autoimmunity in human primary immunodeficiency diseases over 20 years ago in an article that they published in Blood, and pointed out that in very well-known inborn errors of immunity that we would consider to be classical diseases, RAG disease with Omenn syndrome, chronic granulomatous disease with Scott-Aldrich syndrome, X-linked lymphoproliferative disease, CD40 ligand deficiency, autoimmunity was quite a feature of these diseases. So this is not a new concept. It does, however, now have its own sub-classification, and in the International Union of Immunological Societies, it is found in Table 4, where in the last classification 52 diseases were described, and they are summarized here and here. So 52 diseases to get through in the remaining 15 minutes is quite a task. And I'm going to be, I'm not going to be talking about all of them, obviously, because it's too big a job. But we can summarize some general features that are important to consider. So largely we consider, or we can think about failure of central tolerance or failure of peripheral tolerance. And that will segregate into different diseases which will cover at least some of the diseases that we're thinking about. Of course, there are other categories that we might consider. So, and there's also an overlap. So regulatory or Treg diseases at the top, but actually that may overlap with immune dysregulation with colitis and inflammatory bowel disease as well. What I'm not going to talk about today is ALPS or HLH because I was only given 20 minutes and those are really topics that could take 20 minutes each. There are significant diagnostic issues when we're thinking about this, and again, I was rather touched by Boris's naive concept that paediatricians are kind of the fount of all knowledge, and whilst that may be true for paediatric immunologists, I don't think it's true for all paediatricians. And it's difficult because with these diseases there's significant overlap. There is often no correlation to be found between the genotype and the phenotype, how the patient is presenting. Often there's an incomplete clinical penetrance in these primary immunoregulatory disorders, and that's certainly true in pediatrics. It may be that the penetrance becomes more complete once they reach adulthood and go and see Boris and his colleagues, but certainly in pediatrics there may be an evolution of disease, and so the picture is not complete. But even in adults, there may be an incomplete clinical penetrance. And that the organ-specific autoimmunity that we can see in these diseases can actually differ between patients with the same genetic defect and indeed differ within the same family. So as I say, the phenotype doesn't always run true. And there's a huge overlap of clinical manifestations that we can see between these different genetic conditions. So recognizing that the patient has a problem is an important first step to then seeking a genetic diagnosis. But I think it can be very difficult to predict the genetic diagnosis based on the clinical phenotype. And as I say, there is an evolution over time with a gradual accrual of additional problems. So the patient that you see at a few months or just a few years of age may well acquire more symptoms over time before perhaps the diagnosis becomes obvious. Something wrong here. If you can help. What I see on my... Here we go. Maybe that will help. Oh, no. Go back, go back. And again. Maybe try. And again. Yeah. And again, as Boris has said, actually, even in pediatrics, these patients may present to different subspecialists, and they may be unfamiliar with the emerging spectrum that we see in these diseases. And that's not unfair, actually, because I think even as immunologists, it's really quite hard to keep up with the very new advances that we're seeing almost month by month, and expecting non-immunological specialists to keep up with the different diseases and manifestations that we're seeing is really quite difficult. But actually, an immunologist may be the last specialist that these patients present to, and there's a whole range of different specialists that may see them first. I think that's why it's really important as immunologists that we have very good lines of communication with our subspecialist colleagues, and that that we're very open to conversations about patients with unusual manifestations, because a number of the patients that I describe have been picked up from other specialties before they come to us. I think it's fair to say that early onset perhaps predicts monogenic causes of disease. This is a diagram from Holm-Ulig, who's a gastroenterologist, looking particularly at early onset inflammatory bowel disease. But I think it's generally true that early onset perhaps predicts monogenic causes. That doesn't mean necessarily early onset will have a monogenic cause, but it's more likely. But it doesn't mean that later onset rules out monogenic causes, and we've already heard about that from both Fabio and from Boris, that patients presenting later on in life, and maybe even presenting for the first time and not being a late diagnosis, may well have monogenic disease. So always be thinking about the potential for diagnosis. This is an article that was looking at cytopenias and immune regulatory disorders, and looked at two groups of patients, those that had an autoimmune cytopenia not associated with an inborn error of immunity and those that were associated. And there were some differences, not particularly, I think, of sex, although there seems to be there. I think that's mainly because of small numbers. And also not really particularly difference in age of onset. I don't think that that's significant. The diagnosis, I don't think also helps. So knowing that it's an autoimmune hemolytic anemia, ITP, or neutropenia doesn't necessarily help. Perhaps having more than one cell lineage affected might just raise a suspicion. But the really important thing is the fact that within those patients that had inborn errors of immunity, there were other features going on. So there was maybe a family history, or the patients also had hypogammaglobulinemia. Maybe there were other organ systems that had evidence of autoimmunity. There was perhaps associated splenomegaly or lymphadenopathy, and so on, infections particularly. So I think when we're evaluating patients who've got autoimmunity and wondering, well, could they have one of these immunoregulatory disorders, then the careful history is really important. Are there any other features going on that might suggest that this isn't just autoimmunity, but might be part of a wider syndrome? And also, interestingly, those that had an inborn error of immunity, on the whole, needed more significant treatment than those that didn't have. And so more of them had first-line treatments, but importantly, more of them failed that first-line treatment and needed further treatment, and indeed went on, if you like, to the ultimate treatment of stem cell transplantation. And this cartoon just demonstrates some of those gene defects that were found in this group associated with inborn errors of immunity. Now, I said that I wasn't going to talk about autoimmune lymphoproliferative syndrome. This is the diagnostic criteria for that. And the reason is because it's fairly well described. But what we're thinking about is diseases that are not ALPS, but perhaps Alps-like. And increasingly these days, we're perhaps moving away from Alps-like as a description because we are finding more genetic diagnoses that we can now explain the features that we can see. But this was an interesting paper from just a couple of years ago, comparing the immunological phenotype at the top of patients who had ALPS with that of patients below who had an Alps-like phenotype. And you can see that there's a significant overlap. I think it would be very difficult to see a patient in the clinic, to do immunological investigations, and to be confident that it was Alps rather than Alps-like. And I think in these days of increased access to genetic testing, really that's where we need to be going early on, because it's only by doing genetic testing that we're going to find out what the diagnosis is. And this is looking at a group of patients who had Alp-like syndrome and their eventual genetic diagnoses. And you can see that there is a huge list here of patients that present like Alps but actually have a different genetic diagnosis. And that's also manifest here, showing the different symptomatology that they may present with. So neurological features, lymphadenopathy, endocrinopathy, and so on, and a whole number of different genes fall into that and overlap with that. And I do think it means that when we're looking at these patients, it can be very difficult in the clinic to be confident what the genetic diagnosis is, and simply the important thing is to recognize that there might be a genetic diagnosis and therefore go looking for it. I'm going to go through just 2 or 3 cases with you. So this was a 12-year-old female that we had referred. She'd had recurrent respiratory tract infections from the age of 6 months, needing IV or oral antibiotics. At the age of 4, a CT scan showed that she got bronchiectasis, and she started immunoglobulin. Disease progressed. At the age of 4, she had hypothyroidism. She had recurrent oral thrush, ulcers, and failure to thrive, as well as episodic diarrhea associated with a high fecal calprotectin. And she turned out to have a STAT1 gain of function mutation. And the next case was a 14-year-old male with a long history of lethargy and rash. He'd had a long-standing purpuric rash associated with fatigue frequent nosebleeds. He had a big spleen. In fact, he'd had his spleen taken out. He presented to the haematologists. But despite that, he still had a low platelet count, and he had a widespread low volume lymphadenopathy. He was found to have normal lymphocyte subsets, but he was anemic. He had a low white count and thrombocytopenia. He had some autoantibodies. And interestingly, going back in the history, he'd had a prolonged episode of chickenpox when he was aged 5, and also prolonged episode of molluscum. And we took him to transplant based on the history, and as we were transplanting him, we got the diagnosis that he had a STAT3 gain-of-function mutation. And then the third case is a 4-year-old boy who's had frequent upper respiratory tract infection, pneumonia from at the age of 8 months, and then followed by recurrent chest infection, and indeed by the age of 4 he's got bilateral bronchiectasis. He had a tonsillectomy at the age of 5. He had cervical and axillary lymphadenopathy, and he had no vaccine antibody responses. And he turns out to have APDS. And so I think if you go through those histories, there's clearly quite a lot of overlap in those, and it would be difficult to be confident in the clinic that you've got a specific diagnosis, but I think you could also be confident that this isn't normal and requires further investigation. So just to go through some of these diseases, STAT1 gain of function, common cause of chronic mucocutaneous candidiasis, but also other infections, including bacterial and mycobacterial infection. One of our first early patients actually presented as a query SCID at just a few weeks of age with a pneumocystis infection and was ventilated. We didn't go on to transplant her, but I must admit, now that she's transferred to the adults, I do wonder whether we should have done that. Autoimmunity is a significant feature of this disease, particularly endocrinopathies, thyroiditis and diabetes. And in fact, this girl's brother was also affected and recently died as an adult of a diabetic ketoacidosis. There was a big survey published 2 or 3 years ago now, a big international survey of over 250 patients from 40 different countries, and you can see that mucocutaneous candidiasis is a common presentation. It usually occurs fairly early on in life, but the onset may be later on. And this was looking at the survival. So patients without severe complications had a reasonable survival, but those patients with severe complications, actually the outlook was not good. And I think these days, certainly patients with significant complications, one might consider fairly heavy-duty therapy, including things like JAK inhibitors, but perhaps even in the most severe cases, stem cell transplantation. And these are a list of the other clinical features that these patients can demonstrate. So again, a wide overlap with some of the other diseases we've been thinking about. STAT3 gain of function, heterogeneous multi-system disease that can include early onset autoimmunity, lymphoproliferation, susceptibility to infection, and also these patients can have growth failure, and you can see that list of issues with a different autoimmunity that they may experience. And again, there was a very recently, just last year, a big series of these patients published of over 190 patients. Lymphoproliferation and autoimmunity are significant issues in a large percentage of these patients. And again, those patients who have severe disease, so those that are oxygen dependent or who have enteropathy, who have hepatitis, or who are dependent on parenteral nutrition, have a worse outcome. And again, for some of these patients, stem cell transplantation may need to be considered, although not all of them. And then finally, APDS. This is a PID due to mutations which prevent T-cell activation or differentiation, gain-of-function mutations leading to an accumulation of affected T-cells, poor thymic output, so you may find decreased naive cells and TREX, decrease in regulatory T-cells, accumulation of immature B cells, and a lack of class switch memory B cells, and these patients may well have hypogammaglobulinemia. Presenting with respiratory infection, recurrent respiratory infection, bronchiectasis, as I demonstrated in our patient, herpes viruses infections, but also autoimmunity and lymphoproliferation, including potentially lymphoma. There are a number of treatments, again, available for these. This was a manuscript from a couple of years ago, really looking at transplant outcomes. I think transplanting these patients can be difficult. I think particularly if they're on treatment to control the disease before transplant, which is a good idea, we do need to stop it early because there seems to be some selective advantage otherwise to recipient cells, which might lead to graft failure. And you can see that the graft failure-free survival was not as good as the overall survival. However, there is a new kid on the block, leniolisib, which is a selective PI3 kinase inhibitor. And I think the role of this drug in the treatment of these patients is unclear. We were talking about this just yesterday. I think it clearly has a role, probably for most patients actually. I think as a pediatrician, I suspect that patients that are severe enough to need treatment for this disease probably ultimately need to go on to transplant. But using something like leniolisib as a bridge to transplant may well be a good option, because certainly there's evidence that it leads to a reduction in lymphadenopathy and also splenomegaly, which can be important in a transplant situation, as well as an improvement in the immunological parameters. But I think quite where some of these drugs fit in the treatment pathway, and certainly in the treatment pathway to stem cell transplantation, still needs to be worked out. So I think in conclusion, primary immunoregulatory disorders are a growing area of inborn errors of immunity. Of course, they've always been there, but we are recognizing them more and genetically identifying more of them. Because of this huge phenotypic and symptom overlap, it means that patients may have quite a diagnostic odyssey before they see a suitable specialist who makes the final diagnosis. And that's true, I think, in pediatrics and in adults. And in fact, these patients may have a journey that stretches through childhood into adolescence and early adulthood, or perhaps even later adulthood. And therefore, I think we need a low index of suspicion to consider the diagnosis in these patients. And Fabio and I were talking last night, it's really difficult these days in clinic when you see a patient who's perhaps got one symptom of autoimmunity to know what to do with them. And if they come with autoimmunity and IgA deficiency, what do you do with these patients? Are they going to have one of these diseases or not? I think if they come with two symptoms of autoimmunity, two organ systems, then that certainly ranks up the possibility. But also that family history is really important. And if there are other red flags that I've listed, then genetic screening should be not only considered but actually undertaken. And it's important because there are an increasing number of treatments available, including immunosuppression such as JAK inhibitors, but also the selective molecular target inhibitors as well. And that also leads potentially to stem cell transplantation. And what is the role of that and the timing of that with these diseases, I think we don't clearly know. So I'll just acknowledge colleagues at home who've been helping looking after these patients and diagnosing these patients, and I'm happy to take questions at the end with everybody else. So thank you.